So we've talked a lot about the clinical trials, but of course the drug development process is much longer. So it starts with studying the disease, and Volker introduced this as well, getting an idea, so what is wrong, how can we maybe counteract this, testing it in cells, testing it in animal models, and then we have the clinical trials, and then eventually, hopefully, things are approved. But it's good to bear in mind that this takes many different steps, and that each step, each follow-up step is more complex and more difficult than the ones that we've already successfully gone through. So the next step is more complex, and the fact that something works in cells doesn't mean that it will work in mouse, and it doesn't mean that it will then work in humans. It's also good to bear in mind that a clinical trial is basically an experiment in humans. And very often we say, well, the trial failed, and what we mean to say then is, well, we hoped that this treatment would work, but we did the clinical trial, and the trial showed that the treatment did not work, or that it was not safe. Well, that is what the trial is supposed to do. Of course, we hope that it works, but if the trial shows that it doesn't work, the trial didn't fail, the treatment sadly failed. So we need to be very clear when we use this word failed trial. So for me, a failed trial is when the trial design was such that at the end of the trial, we don't know whether the drug worked or not. So we really have to be careful about how we discuss this. So I was asked to talk about communication, and I think when we communicate, there's humans involved. So there's a sender and a receiver, and things can go wrong on both ends. So I think that is important to bear in mind. And we're going to do it interactive, so get your mobiles ready, because I have a question for you. When I say Barcelona, what do you think of? And don't worry, it's anonymous. There will not be a fail or pass. There will not be judgment. So just feel free to say, when I say Barcelona, what do you think of? And I think, we should start seeing. People are typing. C, yeah, city. Freddie Mercury, yes, good one. Gaudi, tapas, food, football, sunshine, Sagrada Familia. So many different things. So I got robbed there once. So for me, it's also the police where I had to wait forever. So there's many different things, and none of these are right or wrong. It's what you think of when I say Barcelona. And this is also, and to make things complex, sometimes there's also one word that can mean different things. When I say Hamilton, there's many different things that you can think of. You can think of the Formula One driver, you can think of the Broadway musical. When I say I saw Hamilton on Broadway, you will not think Annemieke saw Lewis Hamilton on Broadway, you will think she saw the musical on Broadway. But it's good to bear in mind that when we send and when we receive, because we have different contexts, different things may happen. So don't worry, there will be more questions and interactive things. So how do scientists communicate about science? The most important thing that we do is we publish. And you've seen examples of publications already. And how this works is that the publications are peer-reviewed. So we summarize our work, we tell that this is the methods that we do, these are the results, this is how we interpret them. And then there's colleagues that will look at it. So I will submit something, and then, for instance, Volker will look at it. Does this make sense? Is there maybe a control that she didn't include? Maybe the conclusion is not correct. Maybe there's an extra experiment that you really need to do. And then there can be several rounds of back and forth, and in the end, the reviewer said, well, now I'm convinced that what you published, what you say, this is correct. And then it will be published, and then the world will know about the science. And there's two types of scientific journals. There are those that are in good standing, and the ones that you've seen today, like these are the ones that have a good reputation. They are prestigious. This is where you want to publish. But scientists are also evaluated by how often they publish, and when you publish, you have to pay the journal to publish. So that, of course, gives an incentive to some people that say, we'll set up a journal, and then the scientists can publish, and then when they publish, they pay. So that's a business model. We don't really care about the scientific soundness, because the more we publish, the more money we earn. And then there's scientists that say, well, the more we publish, the better our career will go. So this is, say, the predatory journals, they're called, and they will publish everything. And the bottom line is that don't believe everything that is published. And there's online, so if you Google, like, is this a predatory journal, it will say yes or no. And then you know, okay, so maybe this publication is not that scientifically sound. Maybe this is just one of these business model getting people rich and advancing careers with wrong ways. So just be aware that this is happening. Now, work is also presented at scientific conferences, and then what the idea is that there will be a room full of scientists, and they are the reviewers, because they will ask the critical questions, and if there's an error in thinking, people will tell you this. And this is why very often if you hear a scientist present to you as a family, you will think, yeah, but why are they repeating themselves? Well, that's because they're used to having to convince a group of scientists, not showing just this, but also this. We tested everything. So again, be aware of that. So how do companies present when they've done their clinical trial? Usually, especially if it's a public company, there will be a press release, like, this is what we found. And this is not peer-reviewed, so this is what the company tells. Of course, they have to base it on facts, but they can spin it any way they like to make it look more positive. Very often there will be a quote of an academic, but if Annemieke is very positive and Volker is very negative about the compound, they're not going to ask Volker to provide a quote, they're going to ask me, and vice versa. So again, be aware that this is a lower level evidence. Then there's also publications. The company also want to publish because that is more credible, but that takes time, so that happens later. This is peer-reviewed, and of course, often in clinical trials, there's also academics involved, so this includes academic authors, and then you have all the data. You can look into the nitty-gritty, what did they do exactly. Also, companies can present at conferences. Usually, they will ask an academic to present on their behalf. Again, the content will be agreed upon. Again, they're not going to ask someone who's really negative about the development. They're going to ask someone who is positive. So just bear this in mind. So when scientists present about science, remember they are humans. Humans can make mistakes. Also, scientists are enthusiastic about science, really often passionate, especially their own science. So again, bear in mind that that is happening. Scientists are not trained to present to lay audience or families. So they will use jargon, words that you're not familiar with, and also they overestimate the level of knowledge. So we've been training for years and years and years, and we forget that the level of knowledge is what you learned in high school, and then you never went back to that. So that is sometimes also makes it difficult. So if you hear a scientist present something and you don't understand, that is not your failure as a parent, that is the failure of the scientist presenting. So scientists are trained to be critical, but usually they're much more critical about others than about themselves. And I mentioned it already, scientists are humans. This is of course what we all do. So what I do every day, I try to read a paper, and then I will tweet about it on Blue Sky nowadays, and I will summarize it. So what was studied, what was done, what are the positive things, and if there's criticism, I will give it. And like if they missed controls, if they draw the wrong conclusions, I will tell you. The relevant threads, so those on Duchenne are also on the World Duchenne organizations, and because I've been doing this for, well, over 4 years, I have now some ideas of things that I often see going wrong in scientific papers. So I'll just illustrate it with some examples, and as I said, it's going to be interactive. So what we have here, we have the MDX mouse, a mouse without dystrophin in the muscle. It has pathology. So you see in orange, you see the diaphragm, so the respiratory muscle function, untreated, and then in blue we see treated, and we see that the blue one does better than the orange one. So how well do you think this treatment works? Doesn't work at all, works a little bit, works quite well, it's amazing. I don't know how well it works. No one thinks it's amazing, but yet. But well, I think so. I don't know, but also works well, works a little bit. I'm now going to show you the same slide, but then also with the healthy mouse next to it. So this is what the healthy mouse function is. And now you see, if you compare the untreated and the treated one, actually the drug does only very little bit. But if you don't show the healthy control next to it, you will not know. And there's many publications, many scientific publications, where they don't include the healthy mouse. And then, well, you can inflate things a lot. You can say, ooh, it's much better. Yeah, but if the healthy one is much, 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 much better, then how relevant is this increase? So that's one thing that very often happens. So another thing that many scientists, they will not interact with patients and with families. Like clinicians will see patients, but researchers don't always see patients. So they see their animal model or they see their cell model, and they may see things that go wrong in that specific cell or animal model because there's no dystrophin. And then they might want to treat that. But if that is something that's not at all happening in patients and not relevant for the patients, then what we're basically doing is we're developing a treatment for the model. And then that may work for the model, well, hooray for the MDX mouse community, that's not going to work in the patient. So also be aware of that. If you read about, yeah, but this was reduced, but you think, yeah, but our sons don't have that, well, probably this is what's been going on. Then there's publications, so if they're in good journal, then these are relatively reliable. But also, if a publication is nice, an institute will want to have a press release. Look at our great researchers. They found this really nice, they published this really nice paper, and then they hope that the media will pick this up. So one example, there was a paper in Science a couple of years ago where they tried to do the gene editing that Barry already introduced in a dog model. So they used CRISPR, and they tried a lot, they optimized a lot, they mainly did it with local treatment in the muscle, not that relevant. But then in 2 dogs, they said, let's also try to treat it systemically. So we inject it in the bloodstream and we see what happens. We do a low dose, nothing happened. We do a high dose. In the high dose, they saw dystrophin came back. That's the only thing that they saw, and it was a Becker dystrophin, so not a normal dystrophin, a Becker dystrophin, but they managed, which was great. And they were really modest. They said, well, this is the first step. There's so much more that we need to study, but step 1 has been done. So then the press release came, and the media picked this up. And the first thing came, in dogs, CRISPR fixes muscular dystrophy, but human trials are far off. Well, it didn't fix the dystrophy. They didn't look at how well the dogs were functioning, how they were declining. They had one time point, and they just saw dystrophin in 1 dog after intravenous delivery. So this was the first. Human trials are far off. A few hours later, CRISPR halted muscular dystrophy in dogs. Again, that's not what they looked for. Are humans next? But at least with a question mark. Next day, CRISPR gene editing successfully stopped Duchenne muscular dystrophy in dogs, and human trials are next. Now this publication was in 2018, and in Europe, in the US, there's no concrete plans for CRISPR trials. So I think this is the hype. This is what you will pick up if you go on the media. And then, so just take it with a pinch of salt, as the title already said, because this is what's happening. And of course, this is clickbait. People will read this much better than if you just say, well, CRISPR restored dystrophin in 1 dog. But just be aware that this is happening. So Barry also already mentioned drug repurposing. So what that is we have a drug, it's approved for a specific disease, and then you think, well, but that symptom also happens in Duchenne. So, for instance, fibrosis. If you have an antifibrotic drug, well, Duchenne patients have fibrosis, maybe we can use this. And then the development can be quicker because you already have a lot of safety data, you already have data in humans. So there's examples. So for instance, we have a treatment that's normally used in cancer, and in our MDX mouse, it shows promising results. So we see better muscle quality, we see better muscle function, and it's not one group, it's multiple groups that independently show this. So it's a robust finding. So what do you do now? Do you do, or well, either you're a clinician and what do you do, or you're a family member, what would you propose? Additional preclinical studies in animal models. I start with a early stage trial in Duchenne patients, or I move immediately into phase 3 because we know already a lot. This is used in humans already. So we can move immediately because Duchenne patients don't have time to waste. And we should just skip these early stage trial and preclinical studies. So we see about 50-50 moving to the phase 1 trial or the animals. Oh yeah, it's really 50-50. Some people would like to go immediately to the phase 3 trial. And again, as I said, there's no right or wrong, because I said, what would you do? And well, that you can answer that, and you will always answer it in the right way. But there's some things to consider. So is this a chronic disease or an acute disease? With cancer, very often you will treat briefly and then you will stop the treatment. With Duchenne, you will have to treat forever. And in this specific case, this was a treatment that you could not give for more than 6 months. Well, that's not that useful for Duchenne. Is there safety data in children? Because many times with Duchenne, you will also need to treat children. And again, can you use it for long term? The route of administration is important. So if this is a really, really big capsule, and that's the only way to give it, well, for many Duchenne patients, there's swallowing problems. Either they're children and they don't want to have a big capsule, or they're older and they have swallowing problems. The dose used in animal models, so even with drug repurposing, some people will use a very high dose, which then, well, mice are very resilient. They can handle a lot. But if you then translate that dose in humans, you say, well, but actually what they're using in humans is 100 times less than what they now use in a mouse. So that's then not relevant. And even if it's safe in one disease, doesn't mean that it will also be safe in Duchenne. Because in Duchenne, there's a lot of muscle turnover, and that, well, gives some stress to the kidneys. The kidneys will handle things, but there might be, if you give something else that also stresses the kidney, that might then be a problem. And of course, Duchenne patients are all on corticosteroid. So if there's a negative interaction with that, then again, you have a problem. So these are things to consider. So I have another example from the MDX mouse. So sildenafil, everyone knows sildenafil as Viagra. So they treated MDX mice with Viagra. And these were older mice. They had already heart problems, which MDX mice develop also when they get older. And well, older in a mouse is 1 year. And when they treated the mice, after the onset of the heart problems, what they saw is that the heart problems improved. So they went away. So they reversed the heart problems, again, in the mouse. And obviously, the media really like this Viagra to treat muscular dystrophy. But listening, so hearing this, Viagra can reverse the heart problems in the MDX mouse. What would you do? If you are a Duchenne patient, if you are the parent or a caregiver of a Duchenne patient, if you're a clinician caring after a Duchenne patient, would you prescribe Viagra? No, might consider it, would wait until trials are done, or yes, immediately. Well, we have again a very mixed, which of course was what I was hoping for, so thanks for obliging me there. So the majority would wait until trials are done, so that is, I think, also what I would say, because a mouse is not a human. Clinical trials were done after this finding in the mouse, and what they found, it doesn't improve myopathy. And if you go into the paper and you really read the details, if anything, it was making things worse. And fortunately, this audience, no one said, yes, I would immediately do it. But there were parents that actually did this. There were fathers pretending erectile dysfunction and then feeding these Viagras to their sons, and to then later learn, actually, this makes things worse. And I thought, well, this is a thing of the past. But when I presented this at the World Duchenne organization meeting, a mother came to me and she said, well, the clinician said, there's nothing we can do. You're in a country, there's no clinical trials here, but we can prescribe Viagra. And then, well, later he said, well, we have to stop it because I now know it's making things worse. These things happen. So be very aware. If it works in the mouse, it doesn't necessarily have to work in the patients. It can even make things worse. Better to wait for the trials. So we already had also this question of would you move immediately into phase 3? And some people were inclined to do this. And very often we say, yeah, but it works in mouse and then it doesn't work in patients, and these mouse models are useless. very often this is not the fault of the mouse. Because what you do in mouse, you do first a proof of concept. I have this idea, does it work, yes or no? If the answer is yes, you then want to optimize. Which dose do I need? Which regimen? Which route of administration? Etc., etc. But there's also companies that say, well, we want to push, we want to be quick, we have no time to waste, we immediately go into a clinical trial. And what happens then is that these are the failed trials, because either they fail because there's safety issues, and then in hindsight they say, yeah, well, maybe we could have used a lower dose because we never tested this in the mouse. Well, that is not something you want to conclude at the end of your trial. Or they're not effective, but then they say, well, maybe we could have changed the regimen. Like, we didn't know all this information because we didn't test it in the mouse. So this is bad. This is not something that you want. And then you can say, well, we skip a thing so it's quicker. Well, actually, this sets the field back much longer. So don't blame the mouse for this. And really, it's important to gather all the information that you need from your animal models before you plan your trial. And one of the things that Volkers and others did, realizing this, was set up the Treatment Advisory Committee for Therapeutics, also called TACT, which is a multidisciplinary committee that really aims to de-risk treatment development. So companies can come when they go from, or academics, when they go from mouse to the first time in humans, or when they go from phase 1 to phase 3, and they can just say, well, this is what we plan, and then there's a group of people, preclinical experts, outcome measure experts, clinicians, patient representatives, etc., that all look at it and jointly give feedback and say, well, did you consider this? Or maybe you really should be doing this. So far, we've been running for 15 years, reviewed more than 80 applications, and we have a lot of experts. And, well, the next meeting will be in May in Athens. So I think this is a very useful tool to try and de-risk and make sure that the companies and the academics that try to do trial do it in the best way to avoid these mistakes that we've been discussing. Bear in mind that there's also a bias in what gets published. Because also the journals, it's much nicer to listen and hear something work. Like a positive trial result, everyone is happy. Pfizer showing that there was no difference in these functional outcomes. That's not nice, but it's still important that it's published. And the problem is that many journals don't like to publish things that don't work. So it's much more difficult. And I think a clinical trial, people will want to publish it, but preclinical, we tested it in a mouse, it didn't work. It's really difficult to publish. If Volker shows something, and I want to say, does it also work in our hands? And I see, yes, that's again difficult to publish. Yeah, it's not new. Well, actually, it's much more robust if we independently show the same thing than if it can only happen in one specific lab. If you try to publish something where someone found something, like this treatment worked, like vitamin B3 supposedly slows down pathology in the MDX mouse, we tried to replicate it, we were unable to. Trying to publish that is really, really difficult. And that means that if something seems to work, and well, there may be 10 different groups trying to replicate it, but being unable to, that then is never published, which is really sad, because then you have the impression that it works, but actually it doesn't. There's also bias in social media. If patients do really well, for instance, on gene therapy, that will be the movies that you will see. The patients that don't do well, these families will not be as inclined to post it. So again, be aware that what you see on social media is the best possible responders. This is not the average, sadly. So finally, something about a recent publication that I did for a paper day, I think last Wednesday, where really things were, well, a bit strange. So let's go into it. So this is the paper, Scientific Reports, actually a prestigious journal, but something didn't go right here. So what is it about? It's about beta-glucan. I posted a picture. I have no stock in this compound. You can get it over the counter. It comes in different types of bottles. It's a food supplement available over the counter. It has anti-inflammatory properties and anti-fibrotic properties. And in Duchenne pathology, both inflammation and fibrosis play a role. So knowing that beta-glucan has anti-inflammatory and anti-fibrotic properties, would you, or would your son, or would you advise the Duchenne patient in your care, would you advise them to take beta-glucan? And I think, yeah, here we see We see many different answers again. And again, like I said, no right or wrong. And it's anonymous, so we see many people would first discuss it. They would want more information, other supplements. So again, we have a bit of a mixed bag, but I think discussing it with your clinician, that's what I'm going to say on the next slide. So about supplements, you may think they are safe because you can get them over the counter, but there's some considerations again. If you take more than the suggested dose, this can be problematic. So you may think, well, if the prescribed dose works, getting 10 times more will work 10 times more. Not the case. If you take more, there can be impurities inside. You can overdose or you can get toxic effects. So don't take more than the suggested dose. That would be recommendation 1. The dose can also vary between batches. These things are much less controlled than medication. So again, be aware of that as well. Now the fact that you can get them over the counter, that doesn't mean that they cannot interact with steroids, with cardiac medication that you might already be on, and this is why you really should be discussing this with your clinicians. Because some of them, it might not matter, you can just take them, but some might, for instance, prevent the uptake of the steroids, or counteract the steroids, or even cause toxic effects with the steroids. So be aware that this can happen, and that the fact that you can just get them over the counter doesn't mean that they are generally safe. Now, back to our beta-glucan paper. So what did they do? They tested this in the MDX mouse. And MDX mouse cannot make dystrophin because they have a mutation in their mouse dystrophin gene. They have muscle pathology, inflammation, fibrosis, muscle weakness. And what they did, they gave oral treatment with this beta-glucan for 45 days, starting when mice were 3 weeks old. And 3 weeks old, that's when mice get, say, weaned and become independent. They used control groups, really good. So a mouse with dystrophin, so the wild type, and an MDX mouse without treatment. And they found increased dystrophin levels after treatment. So they looked in plasma and they looked in diaphragm, and they claim, so the white is the wild type, then the dark gray is the one without the treatment, and the light gray is the one with treatment, and they claim we see increased dystrophin. Now, knowing this, would you take, or would you have your son take, or would you prescribe this beta-glucan? Yes, I want more data. I have many questions. Something weird is going on here. We'll wait a little bit. Some people would want it because they think, well, dystrophin is missing, and if this increases dystrophin, then hooray. But of course, the thing is, the beta-glucan has anti-inflammatory and anti-fibrotic properties. It's not doing anything to the DNA. So how can the MDX mouse that cannot make dystrophin, if you give this food supplement, you don't expect this mouse to suddenly make dystrophin. It doesn't make any sense at all. So also dystrophin is present in the muscle, not in the plasma. So the authors are probably not looking at dystrophin. They're looking at an artifact because it doesn't make sense that you measure dystrophin. And also, if you saw the bars in the MDX mouse were quite high. Well, they don't make dystrophin. Why were these bars so high? So this is not real data. But the disturbing thing is that the authors who are in the field of Duchenne don't realize that this doesn't make sense, but also that the reviewers who reviewed this didn't think, well, but this does not make any sense. So I think that is disturbing. And again, if it was a predatory journal, I would say, yeah, well, this is what you get. But this is a scientifically sound journal. So one other thing, because you can think, well, maybe the authors are just, they don't realize, but also they claim in their discussion that they tested this in patients already, and there they see improvements in muscle strength and functions as measured with the Medical Research Council scale. So I looked up the paper that they based this on. So on the left graph is ambulatory patients, on the right graph is non-ambulatory patients. Dark blue is before treatment, light blue is after treatment. Now look at this graph, because I'm going to ask, do you think that the treatment, so the light blue ones, that these patients do better than pre-treatment? So what do you think? Does this improve the MRC scores? Yes, yes a little, no, or what is this MRC score? We've been talking about trials this whole morning. No one mentioned the MRC score. What is this? And for this one, you can give multiple answers. So if you want to give multiple answers, feel free to do it. So people say yes, only a little. A few people, most people say it's the same, or I don't know this score. Well, I think I looked at it. If you look at it, I mean, there's no difference. Like, this is the natural variation. And also, like, if this MRC score would be really relevant, then all clinical developers would use this score to get their drugs approved. The fact that no one is using it means that probably, even if they would see a difference, you could question how relevant is this. So, take-home message: scientists are humans. They may be over-enthusiastic, so then it's up to you, sadly, as parents, to do a reality check. What is still needed? Be critical when hearing news about Duchenne. Where do you hear it? Is it a press release? Is it a scientific publication? And even then you have to be careful. Is it a news report, EMA or FDA approval? Probably a higher level of evidence. If it's a publication, were the controls in place? Does it make sense? And then, very importantly, don't hype. And I think especially if you're having a patient organization, it's also your role to not hype, because families need to make decisions based on the information that they get. If you expect that something works really well, then you're willing to accept a lot of potential side effects. But if it turns out that it doesn't work that well, and you now accepted all these side effects, which sadly can include even death, then that's not good. So you really need to make sure that you're not hyping things, but that you have realistic expectations, because only then can you make an informed decision. So with that, I thank you, and well, I look forward to the discussion after the break.